Hello, good afternoon, everyone. So my name is Xinjiang Cai. I'm an assistant professor in the Division of Cardiology. It is my great pleasure to introduce a distinguished leader in cardiovascular research, Dr. Howard Rockman from Duke University, who has dedicated his career to advancing our understanding of the molecular mechanisms driving cardiac hypertrophy and heart failure. Dr. Rockman currently serves as Edward S. Orgain Professor of Cardiology, Director of the Duke Cardiovascular Research Center, Professor of Medicine and Cell Biology at Duke University. He earned both his bachelor's degree in biochemistry and a medical degree at McGill University in Montreal, Canada, followed by residency training in internal medicine at Montreal General Hospital and a fellowship in cardiology at the University of California, San Diego. He stayed as a faculty at UCSD in 1991 and then moved to UNC Chapel Hill in 1997 and then Duke University in 1999. A pioneer in the field, Dr. Rockman has made groundbreaking contributions to our understanding of G-protein coupled receptor signaling in heart failure, particularly the role of beta-arrestin biased signaling in cardiac dysfunction. He has also pioneered in using novel animal models such as transverse aortic constriction in mice to study cardiovascular disease. He's one of the few cardiologists I know who uses Drosophila to study cardiomyopathy. His work has not only deepened our molecular insights into heart disease, but also opened new avenues for developing therapeutic targets. Beyond research, Dr. Rockman is a dedicated mentor, having trained over 75 undergraduate, graduate, and postgraduate trainees in his laboratory since 1991. His commitment to shaping the next generation of physician scientists is evident in his passion for his mentorship. I can attest to that from my own experience during my training as a postdoctoral fellow at Duke Cardiology. He recently recruited one of our own, our staff fellow Chin, to Duke Cardiovascular Research Center. In addition, Dr. Rockman also served as the editor-in-chief of the Journal of Clinical Investigation, DGSI Insight, and has received numerous awards throughout his career. It's truly an honor to have Dr. Rockman with us today. Please join me in welcoming Dr. Rockman.
Thank you. Very humbling and very much appreciated. It's an honor to be here to present work from the laboratory, specifically my love of G-protein coupled receptors, and to really go through an evolving area of pharmacology now, allosteric modulation of the receptor. So let me dive right into it. I'd like to start with a case, being a physician, and not I don't always do this, but in this form, I think it has some relevance because many of the therapies that we use now for the cardio and for heart failure are GPCR based. So this is a 32-year-old male. This is actually a person that came to see me several years ago, and he presented to my clinic with 2 months of profound progressive shortness of breath. He had COVID in August 2021 and then developed progressive shortness of breath. His clinical symptoms were clearly related to congestion and fluid overload with exertional fatigue, P&D, and orthopnea. On exam, he was quite ill and with a tachycardia, tachypnea, bibasilar crackles, elevated neck veins, and evidence for low volume heart failure. He had bilateral pedal edema. This was his echocardiogram. I think that most can appreciate that the left ventricle is severely impaired in terms of its systolic function. When his EF was calculated 15%. I admitted him. He was diuresed, and we initiated what we call GDMT, guideline-directed medical therapy now. And so in sequential fashion, you started on the beta blocker, carvedilol, the pivotal trial demonstrating its effectiveness is shown on the right side of the slide. He was then started on Entresto, which is a combination of a neprilysin inhibitor and an angiotensin receptor blocker, another GPCR. And the trial, the Paradigm heart failure trial, was the pivotal trial. spironolactone, and more recently, the more recent trial, DAPA-HF, he was started on dapagliflozin. After 6 days, he was discharged home with a life vest, and we'll come back to this person at the end of the talk. So what about GPCR? So GPCR signaling, the basic unit of a G protein coupled receptor unit is made up of a receptor, a 7 transmembrane receptor. There are over 1,000. We study the adrenergic receptors that are primarily driven by adrenaline or activated by adrenaline and norepinephrine, noradrenaline. Angiotensin receptor is a typical G protein coupled receptor. And in fact, 30% of all FDA approved drugs are targeted against GPCRs. The heterotrimeric G protein is one of the transducers that couple to the transmembrane receptor, and which activate an effector molecule. And for the beta adrenergic receptor, that effector molecule is adenyl cyclase, and that will stimulate the production of cyclic AMP. We now understand that a receptor toggles between inactive and active states. And when the addition of an agonist in the orthosteric site stabilizes a high affinity pose or conformation of the receptor, and that receptor is able to couple to G protein and activate signaling. The structural basis for that has been understood now in the last few years, whereas ligand binding results in conformational changes of the receptor such that the transmembrane loop, TM6 and TM5, rotate out of the way and open up a cavity in the central core of the receptor, which allows for G protein binding. And there's something that's called the ionic lock that stabilizes that in an active conformation, breaks the ionic lock, and the active conformation then is able. I want to point out that this slide summarizes 5 decades of work and 6 Nobel laureates. Brian Kobilka and Bob Lefkowitz for the discovery of the beta receptor and its structure and function. Rod Bell and Gilman for the discovery of G proteins. Earl Sutherland for the discovery of adenyl cyclase. And Sir James Black for the discovery of propranolol, the first beta blocker. Our concept of GPCR signaling has evolved. So as I mentioned, the activation of the receptor through orthosteric ligand binding, an agonist such as norepinephrine, when you get up and run and your heart rate increases, it's because norepinephrine is released from the sympathetic nerve terminals. It engages the orthosteric site of the beta receptor. The beta receptor then is in an active conformation coupling to G protein. Intracellular signaling, cyclic AMP, and you get a heart rate and contractility effect. And we could see that using radioligand binding. And shown here is a competition curve for the radiolabel, say for the beta receptor. And we could see that with increasing cold agonists. And if you add in G protein, you see a leftward shift, demonstrating its binding to a higher affinity state. Subsequently, the receptor, once it's activated, can be phosphorylated through a G protein coupled receptor kinase on its C-terminal tail, recruits beta-arrestin. And in the last 10 years or so, we understand that beta-arrestins do several things. One, they could desensitize the receptor by shutting down signaling, but they could also activate signaling in its own right, arrestin signaling. And you could see that in fact is a different, we don't know different, but we understand now it's a different active conformation that is also activated through beta-arrestin. So there are 2 transducers, at least 2 transducers, G protein transducers and beta-arrestin transducers. And then we also show that one mechanism of arrestin signaling is through transactivation of the epidermal growth factor receptor. Since there are at least 2 transducers, G protein signaling and arrestin signaling, we then understood and showed that in fact you could direct the receptor to signal through one or the other transducer. And this is the basis for what we call ligand bias signaling. So in an endogenous system, there's a very little bias. Norepinephrine activates both G protein and berestin. Although the pattern is different, norepinephrine will activate both signaling pathways. But in principle, and we have developed or identified molecules that could stabilize a conformation of the receptor that preferentially engages a G protein and preferentially engages the G protein to only G protein signal, but won't signal through berestin. This is a G protein biased ligand or agonist. And similarly, for beta-arrestin, we have ligands now that stabilize a conformation that prefers berestin engagement, very little G protein. An example, for carvedilol is a berestin-biased ligand. Carvedilol, we understand, is a beta blocker. And when it engages the orthosteric site, it does not activate G protein, but it doesn't activate berestin recruitment and signaling. And so carvedilol is one of the few beta blockers that is actually mildly berestin biased. But we now understand that there's a need for new pharmacology. And the reason for that is several. One is that if you look at all the beta blocker trials that's shown here, there's huge variation in the effectiveness of these beta blockers. Everything from carvedilol showing 65% reduction in mortality to ones that have very little reduction in mortality. But the biggest problem is that patients need to be on high doses of beta blockers, and in most cases, they're unable to take it. So this is a slide that shows the dose of the percent of patients that were able to achieve the maximal effective dose in clinical trials. And if you look at all the clinical trials, about 80% of the patients were able to get to the maximal dose. But in real world situations, in registries and in the clinic, most patients are not able to tolerate high doses of beta blocker because of side effects. And we know it's important. This is work done by Michael Bristow years ago, which showed that if you look at carvedilol, low dose and the dose that was used in the clinical trial, you could see that there's a dose relationship between improvement in ventricular function and reduction of 6-month mortality, meaning that the highest dose is what's necessary. But patients aren't able to tolerate and frequently do not get are not maintained on these high doses. One approach is to develop compounds or drugs that allosterically modulate the receptor. So what are allosteric modulators? Allosteric modulators are compounds that bind to sites that are not the orthosteric site, distinct from the orthosteric site. They can bind anywhere on the extracellular, on the intramembrane side, on the intracellular side, anywhere that is not at a orthosteric site where the endogenous ligand binds. They can modulate binding affinity, which I'll show you. In other words, how well the orthosteric ligand binds. They could also modulate efficacy, how well the receptor engages transducer and activates signaling. Now, if it activates signaling, either through affinity or through activation of the pathway, these are called positive allosteric modulators, PAMs. If the modulator shuts down the receptor, either reduces affinity for orthosteric ligand or inhibits the pathway, they are NAMs, negative allosteric modulators. And now we've also discovered allosteric modulators that stabilize conformations that preferentially drive one pathway or another. And these are biased allosteric modulators. And another class, then, it's a combination of bias and also allosteric modulation. Why do this area of pharmacology receiving so much interest? Because they have the potential to really set the stage for the next frontier in pharmacology, in receptor pharmacology. Because the allosteric sites are much less conserved than the orthosteric site. If you look at the orthosteric binding pocket across many GPCRs, It looks very similar. It's very hard to develop a drug that has only a specificity for one receptor subtype. Take Ventolin, salbutamol, right? Why do people get tachycardias when they take their inhaler? Because it's an off-target effect of the beta-2 agonist that stimulates the beta-1 receptor, right? You have beta blockers, even metoprolol will block the beta-2 receptor. It's very difficult to get high receptor subtype selectivity. But because the allosteric sites are so less conserved, that something that binds on one area is unlikely to bind to any other receptors, and that's what we find in practice. The other point is what's called the ceiling effect. They're not competitive inhibitors. So to block all the receptors' action, you just need one molecule per receptor. You don't need very high doses. Now think of it for a beta blocker. If norepinephrine concentration is very, very high in the local area, to block that norepinephrine concentration, you need very high doses of the competitive antagonists. And that's why you need very high levels of metoprolol or carvedilol to be effective, because you have to block probably, high micromolar levels of norepinephrine. But an orthosteric agonist or a modulator, all you need is one molecule per receptor, and you shut down the receptor. And this is called the ceiling effect, because the modulator is saturable, and you don't need higher doses to get efficacy. So how do we find small molecules that bind the receptor as allosteric modulators? What we do is what we've used, and I'll show you two examples, two allosteric modulators. We screened a DNA-encoded small molecule library, a DEL screen. And so in this case, a DNA-encoded library, these are chemical compounds that have 3 building blocks. Each one is unique, and each one is tagged with a unique DNA tag, so you could actually identify the ones that you find as binders. So we have a library that's composed of millions and sometimes billions of distinct compounds, unique compounds, each one with a unique DNA tag. We developed a system where we could have the receptor in a native environment, a nanodisk, a lipid nanodisk, surrounded by an HDL belt that is tagged, and that we could then incubate the library with our receptor in a lipid nanodisk, pull down the receptor, and then after several washes, elute off anything that bound, and we could analyze then all the molecules that are bound to this entity, and then do pharmacology. So let me start with compound 6. Compound 6 was discovered in a screen for the beta-2 adrenergic receptor, and this is the chemical formula. And we asked the question, what does compound 6 do in the presence of carvedilol and the beta-1 adrenergic receptor? So this is the beta-1 adrenergic receptor in nanodiscs. And you could see that it does, this is a competition binding curve with isoproterenol. This work was done by Jai-Lu Wang when she was a graduate student in my laboratory. And what you could see that related to the compound 6, then, in the presence of increasing concentration of cold isoproterenol displacing I-125 cyanopindolol, the ligand, you could see that compound 6 has very little effect on shifting the agonist competition binding. Doesn't do much. What was crazy, though, was that when we used carvedilol, we could see an order of magnitude leftward shift. In other words, this compound 6 stabilized an active conformation of the beta-1 receptor that carvedilol had higher affinity to. This was very interesting. And what it suggests then is that it is a molecule that prefers to carvedilol to bind the beta-1 adrenergic receptor. It was unique amongst many of the antagonists that we tested. Here's just demonstrating several of them, but we tested a whole panel. And in fact, carvedilol was the only molecule that this allosteric drug, this allosteric compound potentiated. So it showed positive cooperativity for carvedilol. We did a lot of signaling assays, and we could show that, in fact, it potentiated Berestin signaling because it's a beta blocker, and so it potentiated the bias action of carvedilol. What I want to show you is what we did in vivo. So the idea here was, well, since it potentiates carvedilol, then you could use lower doses of carvedilol and have achieved greater efficacy. So this is shown right here in this curve in terms of physiology. In black is a increasing concentrations of isoproterenol given to a mouse, anesthetized mouse, and we're measuring heart rate and contractility in the intact mouse. And you could see, as you would expect, that as you increase isoproterenol, you have an increase in heart rate and an increase in concentration. If you pre-treat the animal with very high doses of carvedilol, in this case 20 milligrams per kilogram a day, it's a high dose of carvedilol, you block the heart rate and contractility effect to catecholamines, right? That's a competitive antagonist. If you use a low dose, 1/20th the dose of carvedilol, you have a very minimal effect or no effect at all practically in terms of reducing the heart rate response or contractility. So a low dose of the competitive antagonist doesn't block the in vivo response. Compound 6 with the low dose in yellow looks like carvedilol itself. So in other words, there's no intrinsic efficacy of compound 6. So what happens now if you look at a physiologic effect of carvedilol on injury? So what we did is, since Berestin, we've known Berestin to be cardioprotective, we did an ischemia reperfusion model. And in this case, in the intact heart, we did LAD ligation for 45 minutes, reperfusion for 45 minutes, and afterwards pulled out the heart and did tunnel staining, look for apoptosis. And you could see that if you give a vehicle or compound 6, there's about 10% of the cells, mostly in the border zone, that show ischemia, reperfusion, apoptotic injury, right? If you give carvedilol, pre-treat with carvedilol, you reduce this by half. But now if you use low-dose carvedilol, in addition to compound 6, you further enhance the efficacy of carvedilol. So this is exactly what I was trying to explain in terms of the ceiling effect. Lower doses of carvedilol, less intolerable side effects because of that, but enhanced efficacy without reducing, as demonstrating, this low dose of carvedilol doesn't block the physiologic effects to isoproterenol, or for that matter, exercise. We also demonstrated that, as we've shown in previous studies, and again demonstrated here, that the effect of carvedilol is Berestin mediated. So in this case, we used Berestin knockout mice that were flocks that we drove with a myosin heavy chain Cree. So Berestin, the isoforms, both 1 and 2, were deleted cardiac myocytes, did the experiment, and showed that carvedilol had no effect on preventing ischemia reperfusion injury. So the cardioprotective effect of this drug is mediated through Berestin, which we've shown for the beta receptor in other contexts and for the angiotensin receptor. So to summarize compound 6 then, I mentioned what a positive allosteric modulator does, a negative allosteric modulator. This compound 6 is a unique molecule that binds to an allosteric site that stabilizes an active conformation of the receptor for carvedilol and not for agonist. And in a way, the combination of this would make it a super carvedilol agent. Alyssa Grogan in the lab started a campaign to identify new molecules for the beta-1 receptor. And I'll tell you about this compound 11. Compound 11 was discovered by Alyssa using a library that was developed by HitGen. So HitGen, and we collaborate with HitGen, and we obtained their chemical DNA coded library of 1 billion unique compounds made up of about 15 different libraries. And so a library is made up of different R1, R2, and R3 moieties. And basically, we were able to obtain this very diverse chemical library, each one with a DNA tag, and screen a series of targets that we developed over time. And so we use two types of receptors. One is the wild type beta-1 adrenergic receptor. We created a beta-1 adrenergic receptor that had a phosphorylated tail, so it would capture berestin in complex. And what we did is we used a phosphorylated tail and linked it to the wild type receptor using a sortase consistent site and sortase reaction. Down here below are competition curves showing that these receptors have normal affinity for ligand and behave as one would expect. They're allosterically modulated by G protein, the wild type, and in the case of the beta-1 V2RPP, allosterically modulated positively by beta-arrestin. So we know that these are both receptors are able to engage the various transducers. We use 5 conditions. Of course, the controls, empty nanodisk or unligand beta-1 in nanodisk. But importantly, what we were able to, one of the conditions that we used were high affinity ligand activation of the wild type receptor, a wild type receptor in complex with G protein, and a wild type receptor in complex with beta-arrestin, actually not the beta-1 V2RPP receptor, not wild type, in complex with beta-arrestin. In this case, we could potentially find, excuse me, allosteric modulators that bound a G protein complex, a berestin complex, in other words, looking for biased modulators, or unbiased PAMs or NAMs. We pulled down over 30 compounds, and I'm going to tell you a story about compound 11. So compound 11 bound to the mostly the receptor that did not have G protein or beta-arrestin, but it did bind to, in a few cases to some of the G and the berestin molecules. What we show is that compared to DMSO control, vehicle control, compound 11 shifts the affinity competition binding about a half a log. In other words, for affinity, it's a positive allosteric modulator. Okay, it has no effect on antagonist, only norepinephrine. What was really remarkable is that it's positive for affinity, but it inhibits activation of transducer. So we use several assays here. I'll describe 2. One is a true path G protein dissociation assay. This is a luciferase-based assay. And what in this case, what we're monitoring is the activation of G protein by the dissociation of the beta gamma subunit from the alpha subunit. And so a negative curve is activation of G protein. And in vehicle, you can see that in activation by isoproterenol enhances G protein activation. In the presence of compound 11, you have about a 50% inhibition. Another assay is what's called a glow sensor assay, which is another luciferase-based assay that measures the amount of cyclic P. And one can see then that in the vehicle, isoproterenol dramatically increases cyclic P generation, and compound 11 inhibits this activation of G protein. So it's a PAM for affinity, but a negative allosteric modulator for G protein. You could also see the ceiling effect here as demonstrated by the increasing concentrations of compound 11. We then tested berestin signaling, and there's a number of ways to test berestin signaling. In this case, we looked at berestin recruitment, the recruitment of beta-arrestin to the activated receptor through a bread assay, and another type of assay looking at borescent internalization. So as I mentioned, when receptors are activated by ligand and they become phosphorylated, the receptor internalizes, and we can monitor that through another type of bread assay. And you can see here that in vehicle, there's a strong recruitment and internalization. In the presence of compound 11, then we've shut down recruitment and internalization. So compound 11, a PAM for activity, but a NAM, negative allosteric modulator, for both transducer signal. Compound 11 doesn't have any effect on other receptors that we tested. So the beta 2 receptor doesn't have any effect on ligand binding or on activation. The angiotensin receptor has no effect on signaling, either G protein or borescent signaling. And the muscarinic receptor, in this case, we did a calcium flipper assay, had no effect. So it has high specificity, at least for these receptors, for the beta 1 receptor versus the ones that we tested. So where would this have value? Well, we wanted to test and say, well, this now has value in high catecholamine states, right? A high catecholamine state for the heart would be one where there's huge activation of the receptor, but yet you want to diminish downstream signaling. So we tested it in cardiac cells, and we could show that, in fact, it blocks the activation in a cardiac cell, the activation signaling of a cardiac cell. So we looked at phospholambam, the phosphorylation of phospholambam, as shown here with isoproterenol, and compound 11 diminished that phosphorylation. We looked at phosphorylation of troponin. You could see that isoproterenol activates the phosphorylation of troponin I, and that's blocked by compound 11. And if you look at isolated cardiac contractility with isoproterenol, one increasing concentration of isoproterenol, there's an increase in the contractility of the cell, and compound 11 blocks that. So we reason that one disease that would be very amenable to a negative allosteric modulator that could suck up norepinephrine because of the higher affinity would be one that is induced by high catecholamines, and that is CPVT, catecholaminergic polymorphic ventricular tachycardia. So for those that are not aware, this is a genetic disorder. It's a life-threatening arrhythmia that is driven by high catecholamine states, such as during exercise. It often presents, sadly, with sudden cardiac death or syncope in kids, and it induces polymorphic or bidirectional ventricular tachycardia. It's caused by, most commonly, mutation in either the ryanodine receptor or in calsequestrin. The mainstay of this therapy, as you would imagine, is to block norepinephrine, and that is beta blockers. My pediatric cardiologist tells me, good luck. Kids don't take beta blockers. They tell you that they're taking it, but they don't like taking beta blockers. Why? Because it blocks adrenaline and norepinephrine. And they don't like that because they want to run with their friends. So often other therapies, flecainide, or sometimes even ICDs needed, but kids don't like beta blockers. When you think about it, though, an allosteric modulator is perfect for this disease because if there's no intrinsic efficacy, the kids may take the drug because they feel fine, but if we could shut down signaling, we could be effective. So we tested it in a mouse model of CPVT. So this is a model that we obtained, is a calsequestrin knockout model. And so these are cellular studies. So we're pacing calsequestrin knockout cardiac myocytes at 1 hertz with vehicle. And if you give isoproterenol, you can see that the cell just goes crazy. And if you look at the frequency, then essentially it's the contractile equivalent of ventricular tachycardia. And if you pre-treat then with compound 11, you abolish that increased frequency of contraction. The fundamental mechanism is calcium sparks, the release of calcium with catecholamine. And so we measured calcium sparks in collaboration with Andrew Landstrom. Here are line scan images of a cell. And you can see that paste cells, you see a calcium release event. In the presence of isoproterenol in the calsequestrin mouse, there's dramatic increase in calcium release, typical for the phenotype of CPVT. But now, if you do the same thing with compound 11 pretreatment, you abolish the isoproterenol-induced calcium release events in these CSQ mice. And that's shown here quantitatively, where compound 11 essentially virtually blocked all catecholamine-induced calcium release events. So we wanted to test this in vivo. But first, let me describe some molecular docking experiments. We wanted to know where compound 11 binds to the allosteric site. And so we're in the process of getting cryo-EM structures. But in the meantime, we did some molecular docking using AlphaFold. And what we found is that the pose of the receptor where compound 11 seems to have the lowest energy and the highest docking score is right in the core of the receptor, the core where we know G protein and berestins bind. And in fact, we show that, at least through this molecular docking, what compound 11 does is it interrupts the ionic lock by having interactions with arginine, lysine in TM6 and the serine in TM7, therefore breaking the ionic lock. And that's why the receptor, we think, is in an active conformation. But because it's sitting in the core of the receptor, it sterically prevents G protein or berestin binding. And that's why we see the negative efficacy, the negative cooperativity on transducer signaling. The cryo-EM image will tell us whether this is true or fantasy, and we're looking forward to those data. So we put the mice on a treadmill, and we did a ramp treadmill exercise protocol where mice were on the treadmill with telemetry modules, and we were recording real-time electrocardiograms. And this is a electrocardiogram from a CSQ mouse at baseline when they're just sitting around. They're in sinus rhythm. During exercise, you could see monomorphic VT and polymorphic VT. And we did this prior to or pre-treating the mice after conditioning with either vehicle or with compound 11. And what we could show is that there's lots of VT and that compound 11 diminished the frequency of VT in terms of seconds, anywhere from 25% to virtually abolished all VT. Some animals that had a huge amount of VT, we had about a 50% inhibition, and others, animals with less VT, this is in seconds, had more complete inhibition. And we're on, these studies now are just being refined with the combination of a low dose of beta blockers, such as Nadolol, which is the drug that's often used for with kids with CPVT, and the combination of compound 11. So compound 11 is a very interesting molecule. We're calling this a PAM antagonist, a positive allosteric modulator for affinity, but an antagonist because it blocks signaling. And we think that this would be a molecule or an analog of this molecule. We've made some analogs of compound 11 that look very, very interesting, that would have a therapeutic role for diseases such as CPVT, but others that have high catecholamine states as the disease that's driving illness. Let me go back to the patient then. So 3 months later, he comes to clinic and he's feeling a lot better. Much fewer symptoms of shortness of breath on exertion. I titrated all his meds, and his EF now is 35%. I stopped the life vest. And so 3 months of GDMT made a huge difference in this person. So I want to just bring back a little bit of history. When I was a cardiology fellow in the late 80s, the only thing that we gave to patients with heart failure was digoxin, and Lasix. And this is the first one of the early trials. This is an angiotensin converting enzyme inhibitor, enalapril, called the consensus trial that was published in 1987 compared to placebo. So we're blocking the renin-angiotensin AT1R pathway. The 1-year mortality in patients with class 3 heart failure, EFs of less than 35%, 3 and 4 heart failure, the 1-year mortality was 60%. So when I saw a patient, I knew that the likelihood that this person was not going to live a year was very, very high. Fast forward 38 years later, this is the data from the DAPA-HF trial. Now, the patient population is very similar. All these patients, if you look at the patient population, there were class 3 heart failure, by and large, EFs less than 35% for entry. The 1-year mortality in the DAPA-HF, so these people were on, like the patient, carvedilol or beta blocker, Entresto, spironolactone or another mineralocorticoid, aldosterone mineralocorticoid inhibitor, and DAPA. The 1-year mortality is less than 10%. That's how far we've come based on using GPCRs, but also these other drugs. So let me summarize in the next 2 slides. We understand now that receptors toggle between inactive states, very, very inactive states, and that's something that has led to a concept called inverse agonism, to partially active states, to an ensemble of active states, depending on whether it's engaging G protein transducer or Berestin transducers. We also now understand that we can modulate receptors allosterically, not just by G protein or beta arrestin, which are allosteric activators of the receptor and show positive cooperativity, but with small molecules that stabilize different states of the receptor, either inactive or active, by binding to these allosteric sites and potentiating maybe affinity or efficacy by modulating the conformational status of the receptor. We understand that we could use orthosteric ligands to direct signaling, either through G protein or Berestin. We call this bias signaling. A balanced agonist then activates both G protein and beta arrestin. For the beta 1 receptor and the angiotensin receptor, we understand now that G protein signaling acutely is important physiologically. Increasing heart rate, increasing contractility, maintaining blood pressure. Chronically, we understand that to be detrimental in disease, heart failure, for example, by chronically increasing the effects of the sympathetic hormone, causing cell death, vasoconstriction. We understand that beta arrestin can be cardioprotective. And if we could activate beta arrestin, then this would potentiate the good things that beta arrestin do in the heart. G protein bias ligands then will activate G protein, obviously, and Berestin bias ligands would preferentially activate Berestin signaling. And carvedilol is an example, and compound 6 potentiated that effect. And then lastly, the 2 examples that I used are compound 6 and compound 11. Compound 6 potentiates carvedilol to stimulate Berestin signaling. So it's a biased allosteric modulator for carvedilol. And then compound 11 is a PAM antagonist by enhancing the affinity for norepinephrine, but shutting down signaling as a negative allosteric modulator, and it has use for high catecholamine states. So with that, I'll stop. This is the team that has done the work and continues to do the work. I'd also like to thank my good friend and colleague, Bob Lefkowitz, and the people in his laboratory that we work together and collaborate on many of these projects. The Landstrom lab that performed the calcium spark assays, and the cardiovascular physiology core for the in vivo mouse models. Thank you very much.
Thank you. That was a very informative talk. I have two quick questions. One is, do these compounds cross the blood-brain barrier? And two is, with regards to compound 11, if they're still shutting down the actual G protein and beta-arrestin coupling effects, wouldn't the kids still not be able to run as fast as their friends and so not want to take the drug?
Right. So the interesting aspect of this, so to one is, I don't know if they cross the blood-brain barrier. I don't know that. We're in the process now of doing these toxicology and pharmacokinetic studies. So I don't know if it crosses the blood-brain barrier. One thing unique about allosteric modulators is the fact that by and large, most of them have what we call, they don't have intrinsic efficacy. They're only effective in the presence of orthosteric ligand. So just by itself, they bind to the receptor, but don't do anything. So just by in low catecholamine states, they will have very little effect. Now, it is true that in very high catecholamine states, like exercise, it may blunt the heart rate response to some degree, and that's true. But it probably, our experience, though, at least in the animal models, is that that is much less than in an orthosteric beta blocker. So it's the cooperativity between the antagonist and the allosteric ligand.
That's a great talk, Howard. So question about compound 11 or compound 6, either in the carvedilol locked-in state or... So how does it affect the cycling of receptors from the cytosol to the membrane? Because you would think that maybe these drugs, by allosterically binding and blunting catecholamine response, probably have more receptors being cycled to the surface.
So these studies are ongoing. If they are negative allosteric modulators, they will blunt and say they blunt the recruitment of beta-arrestin. They will diminish intracellular internalization of the receptor. Why this is important, though, is that we now understand that a lot of signaling in the cell, both G protein and berrestin, is internalized receptors. That we often thought that, well, it's just on the plasma membrane, and the cells take just throw out, and the whole thing gets diffused all over the place. That's actually not the case. We know that there is localized receptor and whole units in different parts of the cell, and that the internalized receptor really drives a lot of our signaling. So if you want to block signaling, you often need to block internalization. And compound 11 would do that, for example. In terms of recycling, well, I'm not sure. It's possible that typical affinity for these allosteric modulators are micromolar affinity. And so the likelihood is that they will recycle, maybe a little slower, just as the normal recycling occurs. We'll have to see if that's the case.
Thank you. Thank you for that wonderful talk, Dr. Rockman. My question is related to Marmar's question about kind of the effect of compound 11. When you had those mice on the metabolic treadmill, were you measuring VO2 max? Like, do you see any decreased fitness parameters?
So we didn't measure this. It was simply ECG telemetry modules. We're in the process now of looking at what their functional capacity will be. We did a study where we ran them to exhaustion, and they ran just as long to exhaustion, so that's good. But they're currently now being slated for metabolic cages and running, and we'll see whether they affect what their functional capacity is, what compound 11 does, I should say. Mm-hmm.
And I think your work on CPVT is wonderful, and I think that's just clearly just one example of many conditions that are highly adrenergically mediated. I was thinking, even Takotsubo's cardiomyopathy,
another one.
And then, I have a long COVID clinic and see a lot of patients with POTS. So I'm curious if you've looked, at POTS at all, or have thought about maybe applying this in the setting of POTS.
POTS is a clear example that we're going to target. I don't know of a good animal model system to do. So what we'd like to do now, and the other thing is incessant or a VT storm is another example of that, which is high catecholamines. And so we need to move this molecule out from the animal into something that we're being able to test in human disease. But you're absolutely right. POTS, VT storm, these very, very high catecholamine states, Takotsubo cardiomyopathy, these were all ones that we've thought of that need to be tested, or we like to test with compound 11. Yep.
Thank you for this wonderful talk. And forgive me if you've already known this, but in VT storm and in CPVT, we had catecholamine crisis.
Yeah.
And so when you're using compound 11, did you find you had an increase in circulating catecholamine? Because you just affected the binding site and not necessarily changed the release profile from the.
That's correct. So so let me address that. I don't know if I'm addressing your question directly, but like a good politician, I'll just talk about what I'd like to talk about. But let's just review for a second what we know about catecholamine release. So the catecholamine is released by sympathetic nerves and nerve terminals into the synaptic cleft, and it's in very close approximation to, say, where the cardiac myocyte is with the beta receptor. People have measured the actual concentration of norepinephrine in that synaptic cleft, in that very, very local domain. It's millimolar concentration. Now, if you measure catecholamines in the blood, of course, it's much less because it's washed out. But what the beta receptor sees is millimolar concentrations. It's astronomical, and then rapidly taken up by the norepinephrine transporter or washed out. And so instantaneously during these cases, to antagonize that level, you would have to administer, industrial doses of beta blockers to competitively antagonize that level of catecholamines. But an allosteric drug, for that, you only need one molecule per receptor. So if there's 40 femtomoles of receptor, you just need 40 femtomoles of bound allosteric modulator. And you don't care what the concentration is for norepinephrine. So in answer to your question, I actually don't know whether it's going to change the dynamics of catecholamine release. It may, but I don't really care, because even if it's much higher, as long as I have one molecule per receptor, I don't really care what the concentration is. And it could be much higher.
So I think Neil was asking probably a more nuanced question, which is there are adrenergic receptors on sympathetic nerve terminals as well.
Oh, I see. Will it affect
and
the release?
So would it affect the release in addition to giving you the benefit of potentially getting rid of the ones that are sitting around or binding?
I understand now. Yeah, absolutely. I think that
so,
if that receptor is necessary for its release, it would be increased. I got it. I see. Right. It could potentially. And the last thing is that a PAM antagonist, it's a decoy receptor, because it has a higher affinity for norepinephrine, but it's not signaling. So in a way, you're sucking up more norepinephrine as a decoy. So yes, you could decrease release if that's the case. Potentially, for example, or maybe even alter something else and affect on the postsynaptic side. Yeah.
Hi, Dr. Rockman. Thank you for the great talk. So since you showed that the 38 years showing a great improvement of the mortality reduction by the beta-adrenergic receptor antagonist, but do you have any comments on the role of these drugs in its failure in the HFpEF disease, and what's the beta-adrenergic's role underlying in that disease? What do you think?
In HFpEF?
Yes.
Heart failure with preserved ejection fraction. I have no data. My suspicion, based on the fact that beta blockers really don't do anything good in HFpEF, in terms of, I suspect that this would have very little value in HFpEF. The disease is quite different. I'm not sure that HFpEF is a disease of high catecholamine states. It's clearly a metabolic and other thing disease. In HFrEF, heart failure with reduced ejection fraction that have very, very high sympathetic activity, this may have a role. We haven't tested it yet. It's a fairly straightforward experiment to do in experimental systems, and we'll get to it. We're not going to use this. We'll use an analog that we have that's better, has higher solubility. But with regard to your question with HFpEF, I have no idea. We haven't tested it. My suspicion is it would have no role.
All right, there's no more question. Just thank.